as part of the Perinatal Outreach Education Consultation Services contract. Upon completion of the program, you'll be asked to complete a program evaluation, and then you'll be able to download your CME certificate. Any questions along the way, Kathy Taylor, my administrative support, is your resource, and you can contact her at that email address. Our CMEs today are through the Maine Health iCloud system. If you already have an account, hold tight, I'll get you the activity code in just a second. If you don't already have an account, don't panic. It's pretty easy and straightforward to do by going to this address. And again, if you don't grab this address right now, you can just email Kathy and she'll be able to send you the information. So once you set up your account in the iCloud system, you're going to text your email address, and that's the email that you use to create your account. To that phone number, you'll get an automated reply, which just acknowledges that your cell phone number is now linked to your iCloud account. And then the rest of it's easy. Each time you attend a program that uses iCloud CMEs, you're going to enter the texting code and just to send a text message to that same phone number. This acts as our sign-in sheet for today. You'll get an automated reply that says that we've recorded your attendance. And then after that, we just ask that you fill out the evaluation as previously mentioned. If you want, you are welcome to download the Cloud CME app, because of course there's an app for that. Just that also to mention that our planners, faculty, and others in control of the content for this program today have no relevant financial relationships with any commercial entities. This program will be recorded and will be posted on the Perinatal Outreach Education website. We are not able to offer CMEs if you're watching the recorded version, only for this live session today. Everybody will be muted. I encourage you to use the question box or the chat box, and we'll be monitoring both of those today. Our next webinars are in June 2nd, so following the same pattern, the first Wednesday of the month from 12 to 1. Dr. Alexa Craig will be doing a webinar on HIE and therapeutic hypothermia. And then in August, Dr. Andy Betts, one of the maternal fetal medicine physicians, will be doing a webinar on the topic of management of stillbirth. There is no breastfeeding webinar in July. It's a big vacation week, that first Wednesday in July, and so take a break and enjoy what will hopefully be nice sunny weather. And the breastfeeding webinar series will continue on the first Wednesday in September. Any questions along the way, feel free to reach out to me or to Kathy at the website there or the phone number. And with that, I think I see that it is 12 o'clock, and I want to make good use of everyone's time. It looks like we've got about 32 people have joined so far, and so at this point I want to go ahead and introduce or reintroduce. Many of you already know Kara Catini. She's IBCLC, who's been working with the Perinatal Outreach Education Program for several years now, and then excited that we got a new partner in this work, and Michelle LaRiche is an RN and a CLC who's working at Midcoast Hospital, and she's going to be co-presenting with Kara. So Kara, I'm going to mute and let you take over.
Thank you. All right, let me get to the appropriate screen here. All right, can you see that okay? Excellent. Well, hi everyone. Thanks for being here today. As Kelly mentioned, my name is Kara Kaikini. I'm the breastfeeding consultant for Maine's Perinatal Outreach Program, and I'm happy to be here with Michelle. Michelle, I'll let you introduce yourself a little
Yeah,
further.
I'm Michelle Lariche. I'm a RN and CLC working at Midcoast Hospital, the maternity unit there. Also have worked in the past with public health in the Toronto area with their breastfeeding support programs in the hospitals and community there, and done some also just education and support things for new parents. So happy to be here. Thank you.
Awesome. As Kelly mentioned, we have no financial or commercial relationships to disclose. And our objectives for today are to review the evidence and recommendations for cue-based feeding in late preterm and full-term infants, to identify engagement and disengagement cues in responsive feeding, to review feeding techniques and feeding assessments, and to discuss patient educational strategies for continuing this cue-based feeding at home. So to start, let's review some evidence and terminology, and we'll start with terminology. First, you may have heard the term oral feeding readiness, and that is used to describe the readiness needed to feed orally based on the baby's engagement. And this includes physiologic stability, full oral feeding, and combined feeding proficiency and efficiency, and intake quantity. And infants who are assessed appropriately as ready to begin oral feedings may have improved feeding development. So we'll talk more about that. And then oral feeding quality is another term used to describe what happens during the actual feeding. And it can be assessed using tools like the Early Feeding Skills Assessment or the Neonatal Motor Assessment Scale. Research articles often state that we still need more reliable and valid tools to assess. And if you have a tool that you use in your workplace, it would be great to add that to the chat box. It would be good to know if you have something in particular that you use. And then there's cue-based feeding, which is the introduction of PO or oral feeding with infant cues and engagement. And then you may have also heard about something called infant-driven feeding. And this is a model of care where the infant drives the feeding and the staff are supportive rather than directive. And this is an approach that starts early, before premature infants in NICU in particular start feeding, and it focuses on positive early nurturing experiences and progressed to feeding. So that's something we'll talk more about as well. And you see this Dr. Brown's medical logo. That is because in 2018, Dr. Brown's acquired the infant-driven feeding program from Sue Ludwig and Kara Ann Weitzman. They're occupational therapists who founded this assessment and documentation tool, and they taught about this program since the early 2000s. And then in September 2019, Baby Friendly USA expressed some conflict of interest concerns as a result of Dr. Brown's acquiring the infant-driven feeding program. Dr. Brown's is a bottle, an infant feeding bottle, if you don't already know that. And so due to Baby Friendly certifications requiring adherence to the International Code of Marketing of Breast Milk Substitutes, they had some concerns about this relationship. And they said in their statement had sparked an important discussion among hospital and other staff. They reviewed the comments, which pointed to a lack of a comparable alternative program, improvements to the NICU feeding experience, and alignment with the concept of cue-based feeding. So they ended up revising their guidelines or their guidance rather, and offered measures to mitigate any conflict of interest concerns, like making sure that the staff all understand that their techniques offer readiness indicators that can be applied to both breast and bottle feeding. And it should be the policy of the facility to support exclusive breastfeeding as the optimal form of nutrition, and so on. So that's just something to mention in case you had heard about that bit of a controversy when learning about infant-driven feeding program. Responsive feeding is also a term that's being used more often, and the World Health Organization and UNICEF recommend teaching parents about responsive feeding, which means helping parents learn their baby's cues to know when they're hungry, when they're full, and to not set strict time limits on feeding time. So it's something that some of you may do, and some of you may hear others doing. And so there are reasons, as we will talk about, why not to do that. And there may also be times when it is recommended to set some time limits. So this quote, oral feeding mastery is incredibly complex, yet because eating is considered a part of life, many people may be unable to comprehend the difficulty of this task for preterm infants. And this is a great article, this contemporary review of feeding readiness in the preterm infants. So if you're interested in this topic, it's definitely a good one to read on your own. So it's really important to educate parents from the very beginning, even prenatally, especially prenatally when we can, about feeding readiness so they won't expect too much too soon. So it's easy to get discouraged and stressed thinking that their baby's not doing well when it's actually, their baby's actually doing just what's expected at that gestational age. So it's just as important for staff and professionals to also understand the neurodevelopmental task of feeding so that everyone is on the same page. So for instance, infants begin to show feeding cues at about 32 weeks gestation, sometimes earlier, but not as often. And the feeding skills of sucking and swallowing and breathing, the coordination of all those, they mature significantly between 32 and 36 weeks as the central nervous system develops. And feeding, as we've said, it's a complex neurodevelopmental task for infants. The late preterm infant in particular is at great risk of aspiration if they cannot swallow because of their state of alertness or their maturity or their health status. And infants, especially late preterm infants, tire easily at this stage and age. And also the vast majority of all aspirations occur silently. So it's something to be really aware of. Documentation of the infant's ability and readiness to feed and the response to feeds is key in providing individualized care and communicating to other caregivers. Michelle will speak to this a bit later too. But as we know, the process is dynamic and it can change from feeding to feeding, day to day. So continuing to communicate about that to parents and to your fellow staff members, ideally at the same time when possible, is best practice. So communication, continuity, and consistency are all important. We're always striving for that. But research actually shows that a relationship exists between the consistency and continuity of feeding management practices and improved feeding performance. So there are many reasons why we really want to aim for that consistency. And literature shows that cue-based feeding may actually decrease the time to reach full feeds and ultimately the length of the hospital stay. Inadequate oral feeding is the most common barrier to discharge in moderately premature infants, especially for those with neonatal morbidities. And another study showed that moderately preterm infants with earlier introduction of oral feeding achieved earlier full oral feeding and hospital discharge. They found that for each week earlier at that first oral feed, a full oral feeding occurred 4.5 days earlier, and the hospital stay was shortened by 3.4 days. So if we have a technique that we can use to help infants achieve these earlier feedings, let's do it. And also, feeding difficulties in infancy often lead to long-term eating problems. 40% of all children with feeding disorders started out as preemies. So it's something to keep in mind. We're really trying to set them up for long-term feeding, positive feeding experiences. And feeding difficulties often lead to poor infant-parent bonding. For anyone with older children too, that might be something you understand, this kind of stress and strain it can have on family relationships when there are feeding difficulties. Certainly if this is how you're starting out as a parent with a child who has feeding difficulties, it can be especially stressful. So we really do want to try to promote as many positive feeding experiences as possible, which may include skin to skin during non-oral feedings and oral feedings, and really trying to promote that positive experience. So despite that evidence, change is hard. So for instance, the nurse's workflow. You may be planning to feed a baby by gavage while PO feeding baby Jones, but now the first baby, baby Smith will say, is showing feeding cues. And so it can be challenging for your workflow to always be following your baby's cues when you have a certain number of babies you have to be caring for. It can also feel uncomfortable to feed the baby in a way that's more difficult to measure. That can be uncomfortable for both parents, or for both providers, healthcare providers and parents. But for providers, it can be especially uncomfortable if your documentation tools are more focused on the quantity or the amounts of feeding, not the quality of feeding. So when we're talking about objective versus subjective documentation, your tools might not be set up well for that. Again, feel free to add in the chat box if you have any particular documentation tools you really like to use or that you would like to have. That's good for us to know how we might be able to support you. And consistent education for all healthcare providers and parents is always a goal, as we were saying before, and regularly a challenge. It can be hard to get everyone on the same page at the same time before something changes again. But thank you all for being here today to learn more about this, so maybe you can help your team members as well. And as you all know, successful oral feeds can often be the key to success to sending an infant home. It's something I hear about regularly from moms in a breastfeeding group who their baby was born early, but they wanted to go home, so they weren't able to spend as much time learning about breastfeeding. They had to go right to a bottle and maybe not learn cue-based feeding. So now for Michelle.
So what does a successful oral feed look like? If we're talking about infants who are really concerned about getting certain volumes in, or are they progressing, then this traditional volume-based model often comes up, particularly if that's how your documentation is set up. So you might be looking at how much volume did they take? And if they didn't reach that goal volume, then maybe that wasn't a successful feed. And what do we do about that? Or you might have the perspective that's more cue-based feeding, which is a successful feed that maybe the infant doesn't take the full volume during that whole feed, but for much of the feed, they were active, they were awake, alert, engaged in the feeding, they were maintaining their vitals, they had some good bursts of suck, swallow, breathing coordination in there. And then at one point, maybe they tired out or they somehow got stressed with the feeding and they were just done, and you were able to follow their cues and stop the feeding. And then just give that remainder volume that was wanted or needed, maybe by gavage feeding. So it's kind of two different schools of thought, and look just a little bit more at those. So for the volume-based model, where a lot of times it's set up so that we have these certain volume goals and we're feeding them on a timed schedule, and that's that. And then so whether or not the infant's ready, we're like, they got to have this volume and they got to have it now, and this is with our workflow because we got another baby to feed, and so on and so forth. So the goal for that really though is that they want to get babies up to feeding orally with adequate volumes as soon as possible so that they can get them discharged and home. But this kind of method can sometimes lead to some erroneous beliefs, because if an infant doesn't take the full volume, then all of a sudden they're a poor feeder. They're not doing good. They're not doing their job. And, so then there's this negative connotation there, and stress for the parents around that. And then also nurses can struggle with that. It's like, I'm really working hard to get this baby to eat everything and I can't get him to take it. And now this is like looking bad on me because we're not staying on track with things. So there can be some stress around this method. So the challenge really, particularly in cases where we've got a sick baby or a baby who's losing weight, and we want to be able to get them home, maybe weight loss is getting triggered, your supplementation algorithms at your facility. And pediatricians are really wanting to see those volumes so they can measure the progression to, that they want to see. So balancing that with cue-based feeding is kind of like where we want to be going and moving towards this cue-based feeding, because honestly, if the quality of feedings is not there, if the infant's not engaged and not able to really quite do their full feeding job yet, then you're just not going to get the volumes. You're not going to get the quantity without the quality. So if we can improve the quality of feeds, then that can really lead to those increased volumes and that discharge goals that we're looking for. So it's kind of a tricky thing for nurses to find that balance with things. So looking at cue-based feeding, then this becomes more of a two-way street. We are watching the infant to see when are they physiologically stable enough and when are they telling us that they're ready and able to feed. And also on the other side of that, when are they telling us that they're done with the feeding, that they can't handle anymore? Or they're maybe just not quite ready for as long of a duration, or maybe not ready for this oral feed at all in this moment. So really looking at the baby, and also keeping in mind that this is, we're teaching this child how to eat for the rest of their lives, right? So we want to have it be a positive experience for them, for the parents, and we want it to be something that they're engaged in and that the infant can control, that we're following their cues and following their developmental readiness. So really priority is looking at the quality of those feeds. And then still the goal is the same, to, decrease the amount of time that it takes to reach those full volumes and be able to get them 100% oral feeding so that they can go home. And just a reminder for parents too, that process is dynamic and changes from feed to feed, hour to hour, day to day. So really looking and getting the parents involved right from the start so that they can know like what we're looking for. So what are we looking for here? What are the oral feeding readiness and feeding cues that we want to engage parents in identifying? So I like to point things out in real time with parents when I'm working with them on feeding. Say, hey, do you see this? You see how baby is doing these different things? This is a sign that baby is ready to eat. So feeding readiness is really alertness, engagement, that the baby is ready to be an active participant in the feeding. And there's a big difference if we're talking a healthy newborn and a sick newborn. Really, the cues are the same, but going to be, at different times, and maybe a little bit more subtle with some of the NICU babies or early babies. So we're watching really carefully for those things. First thing is really this physiologic stability. Their tone and vital signs are stable. So your nice healthy babies, ones that have good energy, they're all nice and tucked up together. They've got good tone to their body. Knees and elbows are bent, they're curled up, they have some strength to their muscle. If you try and stretch them out, they're going to pop right back together, that kind of low surface area, and they're going to be actively moving, waking, giving signs. Sick babies, this floppy open posture, there's no energy there. They're just so focused, on just surviving and breathing and things, that they're not giving some of these same readiness cues. Feeding cues, you guys have probably seen these, right? But they kind of waking on their own, rousing, maybe still looking sleepy, but they look, they're kind of like searching a little bit for something, don't know what they're searching for yet, but they're starting to wake up. The mouthing, where they're smacking lips, moving their mouth, sticking their tongue out, rolling their tongue around in their mouth, kind of working things out in there, are nice early cues that we can be aware of. Then they move on to start rooting. If they, you brush their cheek and then they immediately turn to that side, or they're more reactive to that. And then, maybe you offer a finger or a pacifier if that's what's going on with that baby. Or they bring in their hands to their mouth, and anything that they can touch, they're trying to suck on, they're trying to stick in their mouth and go to town. So you're like, man, okay, this baby's really ready to eat, right? And then late cues, the fussing, the crying, like you weren't listening to me, and now I'm going to really tell you I'm ready to eat. So we want to be able to help parents identify those stages of feeding cues, and staff to, and respond to those early cues. So signs of disengagement, the crying, the arching, the baby who seems to be fighting against the breast, moving the hands, pushing away, turning away, or maybe they latch on, but they just sit there and they don't really do anything when the bottle or the breast is in their mouth. And they're just like, sure, not sure what we're doing. Or they just get so tired out and they, lose tone or their vitals, for the early babies, the babies who've had some sort of respiratory distress or things, we wanted to be looking at maybe their O2 sats while they're feeding. What are their respiration rates doing? What's their work of breathing? Are they getting stressed out in these ways? Or a baby that's just like, this is too much. I'm just going to go to sleep. I can't do it anymore. These are the things that we were looking for. Maybe cues we need to stop, and pointing those out to parents again in real time. I'm seeing this. Maybe, for instance, the arching. Even with healthy babies, we see that they've been born fast, or they're C-section babies, and they've got so much mucus and amniotic fluid still in them. It's like, my tummy hurts. I need to burp and spit up. Like, nobody wants to eat when they feel like that. And they often arch and cry at the breast, pushing away. So we can point that out to parents and say, hi, looks like I'm seeing this. Do you see that? A lot of times babies, when they're doing that maybe they need to burp or they need a little rest. How about you bring baby skin to skin and, try some burping, some kind of gentle ways, and just letting parents know that this doesn't have to do with your breast, your milk. This is not, any front to you. This is just baby has something else going on right now that needs to be addressed. So just acknowledging and respecting that. And then sometimes they're ready after some of that break, that time, that rest to breathe or to spit up, ready to go back to breast. And they'll show that too, because they'll start rooting and bobbing and mouthing and ready to go back down and try again. So then say they do have a good feed, we get an oral feed in. Well, how do we know what was the quality of it? How did it go? What are we looking for? So again, there's kind of a list of things that we kind of watch for: the readiness cues, the feeding cues. Were they alert and active during the feeding? Were their vitals good? Did they maintain a nice calm respiration effort? Their O2 sat stayed well. They had some good suck, swallow, breathe coordination. And there's like a maturity process to that also, depending on gestational age and what's going on with them health-wise. How is the latch? There's several different latch evaluation or assessment tools, maybe embedded in your documentation system. So using the tools that you have for that. How is positioning? Was mom able to position baby on her own? Did she need a lot of assistance or not? Was there comfort if she was feeding at the breast? How was that latch feel to mom? Did she feel the strength of it? Was there pulling inside the breast that she felt, or was it just pinchy on the outside? And how were the parents engaged if they're not, feeding at the breast, or they're bottle feeding, or they're gavage feeding and their skin to skin? How's the parents' engagement? How are their skills with whatever feeding technique is being used? That's part of the picture for feeding assessment. Did the baby retain the feeding? Did they spit it all up? Were they able to, maintain? Maybe if they're using some sort of cup feeding, finger feeding, did they lose some of that during the process? And then were there signs that the baby was satiated after the feeding? So hungry babies, stressed babies, they're tight, their hands are tight, their face may be furrowed, they're working, they're, maybe a little fussy, or there's like work and effort going on in the facial expression, and then the body tension. And then as an effective feeding happens, you see that, you're listening for those suck swallows, you're seeing and hearing that. You've got good jaw movement, good latch, whatever. And then the baby is slowly, as maybe 10 minutes goes on or so, 5, 10, 15 minutes goes on. Now all of a sudden there's like longer pauses. And you see baby's hands are like doing this number against the breast, rather than being all curled up, and then whole body gets relaxed. The hands get relaxed. There's milk, around the lips and things, and then they're falling asleep. And even with burping and bringing skin to skin, there's no arousing them. they're conked out. We've got the tip, that, wonderful little milk coma that they were going on. And also mom's comfort, so that's part of it too. Was she having some filling in her breast? Does she feel like the breasts are lighter, particularly as the days and weeks go on? If for those of you that visit at home, mom can look for those things as well. And then retained feedings, no problems with that. And also watching diapers, right? And educating parents through that whole process. So before the feeding, kind of how we're going about this, what to look for during the feeding, pointing those things out, and after the feed, engaging them as a team. How do you think that went? What did you see? And pointing out the little positive progresses. And then documenting all that, really depending on how your system's set up, you may be just volume and there's time and then that's it, but for me in our system at Midcoast, I'm able to write in comments and annotations for each of my fields, what cues were given, how did the parents respond to that, the timing of that. We're wanting to make sure, especially in the first days, that we don't go past that 3-hour mark, so we avoid dehydration and we avoid low blood sugars. Method of feeding, were they feeding at the breast? Were they using an SNS or a feeding tube at the breast? Were they finger feeding? Were they cup feeding? Did they bottle feed? Was it a gavage feed? The type of breast milk, maybe was it straight from the breast? Was it expressed breast milk? Was it fortified breast milk? Was it donor milk, if that's available? What type of formula you might have used? The duration, and then volumes on any of those that you're able to measure. All those quality things that we've talked about. The education and whatever diapers are going on with baby, because those are all nice things that we watch to see the progress. Okay. So second, swallow, breathe, coordination. There's definitely a maturity that happens with that. Immature suck pattern, you might get 3 or 5 sucks in a burst, and then they're pausing for just as long. They're trying to breathe and catch up. They're coming on and off the breast a lot because they just can't even maintain that suction, that latch. And then transitional, we're working a little bit better. We're getting 6 to 10 bursts. Might see a little bit of, respiratory stuff or effort with that. Detaching still occasionally, but really overall they're maintaining more of a latch. They're maintaining those bursts a little bit better. And then mature sucking pattern, you're seeing with well-established latch that they're getting 10 to 30 sucks per burst. And then those swallows are coming more and more frequently, 2 to 1, 1 to 1, with that letdown when mom's got mature milk. And so noting that for the parents, noting those progressions, documenting that so that they can be pointed out to parents is a really nice and encouraging way to kind of boost their confidence with this whole process, which we know can be really stressful. So this feeding readiness scale here was adapted from the Ludwig and Weitzman's infant-driven feeding scale. So prior to feeding a late preterm infant, an RN can use this scale to kind of score the infant and see where they're at. Are they really ready for an oral feed? So looking really for them to score to 4 or 5 on this scale before attempting an oral feeding. So they're waking, with handling. They're starting to give those feeding cues. Either we're eliciting a little bit of rooting, maybe sucking on a pacifier finger, or they've just woken on their own. They're alert. They're giving those cues. They're bringing their hands to their mouth, giving obvious signs. Other than that, if there's no feeding cues, they're not really waking up even when you're doing care with them, interventions with them, or they're sleeping through the care, or they're really needing still a lot of respiratory effect support just at baseline. These are babies that are not quite ready for that oral feeding. And there may be other scales too that you guys use. So if you want to put those in the chat box, that would be great to share. So then for parents, nurses, parents, as they're working on these feedings, some different things to be thinking about and educating with positioning for baby during the feedings. Kind of this modified sideline, obviously imitates a sideline with breastfeeding, but we can kind of incline the baby a little bit too. But having them sideline with their neck and head still facing, just like you would tummy to tummy with mom, can really help them control the speed, that they're not like just on their back getting milk poured into them, whichever the method might be, so they don't get overwhelmed. That can be helpful. There's a variety of, special nipples, nipple shields and things that might get used, but really for specific purposes. Slow flow nipples are often used and great for helping to kind of pace and be closer to a breastfeeding flow. And then burping frequently, but based on baby's cues, if they're doing well, then we're not wanting to like snatch the nipple away from them, snatch their food away from them just to burp them because it's time. Again, it's observing baby's cues and what's going on with them. How's their breathing effort? Are they fussing? Are they not really latching on to the bottle anymore? Maybe they need to be burped. And then external pacing can be done with a bottle, with a finger feed, at the breast. And we've got a great video we're going to show you about that in more detail, but at the breast too, breaking the seal just a little bit, giving baby time to kind of catch up and breathe and not get overwhelmed. Moms have a great milk supply, maybe lying back so that baby's on top versus mom sitting over and then that milk is flowing out of the breast. There's different ways that we can pace at the breast as well. So, and then Kara's going to talk to us about paced bottle feeding.
Excellent. Thanks, Michelle. Leading right into this, external pacing is also known as paced bottle feeding. When we're talking about bottle feeding specifically, you've probably heard about this. You may have seen some videos, and we will show one that's a newer one. But just to help understand why paced bottle feeding is recommended, this does allow the infant to be a little more in control. It also helps them to organize and develop a more effective suck if they haven't developed that yet. But there is a big difference. And this handout is in the resources. It's also cited here on lactationtraining.com. You can see a whole handout on this. This is one part of it. Just explaining the difference between a bottle nipple and breastfeeding. The bottle nipple is more firm. It lands in the front of the baby's mouth. It doesn't really stretch like a human nipple does. And the flow it starts right away compared to when breastfeeding. It usually takes a little bit for that milk to really start to flow. Bottle nipples are quite fast. Even if it's a slow flow nipple, it may be faster than mom's breast and her letdown. Feedings are often rather quick with a bottle, whereas breastfeeding can take 30 to 45 minutes. And sucking on a bottle is like a vacuum process, whereas suckling at the breast is a peristaltic tongue movement. So it's a totally different oral process. And same thing in terms of where the tongue is placed with a bottle feeding versus with a breastfeeding. So understanding the difference can be helpful if people are wondering why you're not encouraging going to a bottle right away, if it may be recommended to do finger feeding or cup feeding or syringe feeding or spoon feeding. These are all of the reasons why. And also, not only is it helpful to teach about this in the hospital and for babies who are learning how to feed in the hospital, but it's also helpful for infants who are being fed by another caregiver when the breastfeeding parent goes back to work. It can be a common challenge for breastfeeding moms to find the time and the space to pump, and then to hear that their babies may have been overfed by another caregiver, or at least fed a significant amount more than what mom is able to pump can be very discouraging. So, you know, maybe babies took 18 ounces of milk while she was at work and she was only able to pump 14 ounces. The baby may really only have needed 14 ounces, but without paced bottle feeding, it may have been a lot, that milk may have been, more milk may have been fed. So again, it can be really discouraging for mom after she's been working so hard to establish a milk supply. And so some of these tips in terms of how, you know, paced bottle feeding should last 15 to 30 minutes, which may be surprising, and it may be harder to do, certainly harder to do without pacing it. And so using that pace technique can be helpful. Holding the baby side lying, holding the bottle horizontal, like in this picture and these other ones. Also letting the baby find the nipple can be really helpful. And that means just placing it right above the baby's lip and then having the baby latch on from there, encouraging a wide latch, and holding the baby cheek to breast can be really helpful. So we're going to show this video. It's cited here, and it's also in the resources at the end. It is a long video. It's about 7.5 minutes long, but we are going to start at right about here.
For any of you that are having trouble seeing that, when she's tilting baby forward, she sucks for a second and then she stops and she breathes. And then when she realizes she wants more, she starts sucking at the nipple again. And then the caregiver is tilting back to release, let her have more milk again.
Thanks, Michelle, for clarifying that. Everything runs fine. Seems fine on my end, but I know it doesn't always come through well. And it's back to you.
Okay, I know. We get so many people on the Zoom. I think sometimes it makes it difficult for some people that don't have a good connection. So, but the link there for that video, guys, is in the resources at the end of the slides. So if you want to go back and watch the whole thing or share that with parents, it is a really great video. Okay, so breastfeeding specific strategies. If we're talking about oral feedings at the breast, with these late preterm or even just healthy, normal newborns that are working on feeding in the first days and weeks, things that we want to be encouraging parents with are and educating them about skin to skin, and the importance of that is like number one. I always tell parents, you know what, this is like their home. It's the only thing they know. And birth is really, I would, for lack of a better word, it's a traumatic experience for babies. You know, it's a huge change and can be so overstimulating for them. So skin to skin, that's home. They feel mom's warmth they're familiar with. They hear her heart rate. They feel her breathing and hear that breathing. Circulation, all of those things are what they're familiar with, the sounds, feels, and the smells to the Montgomery glands around mom's areola that pop up during pregnancy. The oils, those really smell a lot like amniotic fluid that they're familiar with. So many things are familiar for them. But also that skin to skin helps regulate all their organ systems. It helps regulate heart rate and respiration rate. It also has been shown to help regulate blood sugar levels. So, and then it also, when mom and baby are skin to skin, there's all kinds of oxytocin flowing, which is going to only help mom's stress level. Ding, ding, ding. We need to help her with that. And obviously her milk production. So always a good answer. Asymmetric positioning and latching. Really, this is the biggest thing I find, that parents come in and really, if they've never had a baby, and sometimes even parents who have, attempted breastfeeding in the past but maybe didn't have great luck, really don't understand kind of the newest, greatest thing about how to latch a baby nice and deeply to get that optimal milk transfer and comfort with breastfeeding. So working with them and talking with them, like what that looks like, how to get them baby position nipple to nose and tease the nose so that baby, instead of just opening this wide, is giving us that nice, great baby bird gait. I know, where they're reaching for the breast and searching for it. They get that wide gape, then we can get a deep latch. Once, they're on, like bringing their spine in, we're not pushing the head, we're bringing the spine. So teach parents, holding baby along, their spine supported, the little bum's tucked in the elbow. And really, when we're bringing baby on, we're using the wrist and the heel of the hand to push between the shoulder blades, because then we get a baby who, instead of getting their head pushed into the breast, and this is really hard to swallow and eat and uncomfortable, then you get a baby who's pushed between the shoulder blades and they go like this. And now we've got this nice open throat in perfect drinking position. And the chin is deep into the breast to really work those milk ducts. It's just so much more effective. So again, the chin nice and deep, lips wide and flanged to take up wherever the baby's chin is, that side, almost the entire areola on that side, with a little bit of areola peeking out above the baby's upper lips and the nose, then automatically when they're in this position, it's just a little bit more free to breathe, because that's always a big parent concern. Can the baby breathe? And then they're pushing on their breast to get baby to breathe. And really all they need to do is snug baby into a nice snug hug where they want to be. Jaw movement, and looking at the jaw here by the ears and that lower jaw, how is that movement? And we've got a nice deep rocker active movement. Looking at the cheeks, we're not seeing this little dimpling or suctioning. How does it sound? Do you hear sucking, smacking, popping? Those are things that can indicate not a great latch. Mom's comfort. If baby's on nice and deep and really grasping, the whole breast deep into the mouth, then mom's going to be more comfortable and baby's going to get much more milk transfer. And then looking when baby comes off, even if mom felt okay, well, what's the nipple look like when baby comes off? Do we have still the nice round nipple, or do we have a nipple that looks kind of like a new lipstick? If we got a lipstick nipple, then baby was probably too shallow and just chomping on that nipple between the gums. And then that's going to cause damage, discomfort, and really cuts off baby's milk transfer. In the resources, again, there is a great series of breastfeeding videos, guys, that Global Health Media has put out. They have it in a bunch of different languages. There's about 7 different videos geared for medical professionals and also for parents. And there's one called Attaching Your Baby at the Breast. And it's wonderful. I love it because it shows good latches, it shows bad latches, it shows babies at different ages and sizes. And it also does this great, it shows a good latch, and then it shows like a cutaway where they then animate, so you can see what it looks like inside baby's mouth and where the nipples position and how the milk transfers. So go watch those videos. They're awesome. And I actually give those videos to parents all the time to watch. Everybody's got their phones. Everybody's got YouTube on their phones. So it's an easy resource for them in the hospital or at home. Breast compressions. Once baby's on and feeding, I use breast compressions a couple different ways. One, for a sleepy baby, it's a great way to kind of wake them up and get them sucking again. If they're starting to fall asleep, a lot of times a nice deep compression back away from the areola so we don't pop baby off, can stimulate them to start another suck burst when they're ready for it. Also for babies, even if they're starting to nurse better and well, but we're worried about weight loss and we really want them to get the most bang for their buck, then those compressions can really increase how much milk, because now suck and push the milk out. And for some of those, I know among RNs, we talk about, oh, he's a boy. And, sometimes he has a little bit harder time, or maybe there was a little bit of traumatic birth stuff that happened. There was some resuscitation, and those babies really want that instant gratification because they're so tired. And if we give that instant gratification, then they're more apt to keep going and gain some skills there themselves. And then triple feeding, and in cases where we're really needing to really work on it, breastfeeding's been hard for whatever reason. This technique of breastfeeding on demand according to baby's cues. If baby's having a hard time, not achieving a latch, is stressed in some way with vitals or work of breathing, stability, mom's getting so frustrated because baby's on and off, and they're just struggling there. Limiting that feeding time and the attempt to latch to like 10, 15 minutes. If we're not at that point, particularly for like blood glucose babies, we don't want them being stressed, working through all their blood glucose, working through and getting physiologically unstable with the feeding. So we're limiting those attempts and then moving on, supplementing them if needed. So this process of like breastfeeding and then supplementing and then pumping to maintain breast milk supply, because whatever baby didn't remove, we've got to remove for them until baby is able to do it on their own and becomes more efficient. that's a long and stressful process for a lot of parents. And so if we can combine some of these steps where supplementing can be done at the breast, so you're combining 2 steps, or if we've got a second parent, they're feeding baby while mom's pumping. So combining step 1 or 2 or step 2 and 3, that can really save time and stress for them. But this whole process is not a long-term solution, right? It is the bridge to get to baby feeding completely orally and efficiently on their own. So you need to keep that in mind and remind parents too. This is a bridge. This is just temporary. So when we're in the hospital and we're developing feeding plans for these families, again, kind of the steps that I go through with my patients and in tandem with our pediatricians and our lactation staff. Again, skin to skin, always a good answer. This is where we start, and really 24 hours a day, there cannot be too much skin to skin. So doing that, the cue-based feeding on demand, supplementing, obviously we want to use express breast milk first, pasteurized donor milk, if that's available, as a second choice, and then formula as a third choice, just to give baby the best nutrition that they can get. And then lots of different options and trying to figure out what's going to really work for the parents. If we can do an SNS or a syringe with a feeding tube at the breast, great. But finger feedings, spoon or cup feeding, bottle feeding, gavage feeding, depending on what's going on with that infant, what can be tolerated, what the family needs as well is important. In your resources, there are some links to breast storage guidelines from the CDC and from WHO formula preparation guidelines. In the hospital, a lot of times we're using just the ready-made liquid formula that's sterile. Powdered milk cannot be sterilized. So it's really important to take a look at those and share that information booklet and handouts with parents about how to safely prep that formula. Hand expression and pumping, I would just say a good way to do that is really starting with small syringes, small medicine cups and spoons, because that's most encouraging to moms. And Global Health Media has a great video about how to hand express. And then more skin to skin, relaxing and enjoying each other in between feedings and trying to get that whole process down to like 45 minutes to an hour max, so that they have time to rest and recuperate in between and enjoy each other. Consistently evaluating and revising after each feeding, as needed, using that good nursing process. And then discharge planning is super important for these families. What are the parents' goals long-term? That's so important to think about too. What's going to be sustainable for them at home, making sure they have adequate education and that they're independent with their feeding plan before they go home with baby. And then also making sure that they have outpatient support phone number, somebody they can call, and those follow-up appointments with pediatricians and lactation staff.
Great. I just want to do a quick time check here. And then we have a couple minutes. We'll wrap up in the next couple of minutes. But if you have questions, we want to allow a couple minutes for questions too. If you have questions, please think of those and type those into the chat box or the Q&A box. And we'll continue on for now and wrap up in a couple of minutes. Thank you.
So before we, I do just want to pop out this one question that came through our chat really. Has anyone seen the new Minby bottle nipple option for families? It's being advertised or sold as mimicking a breast. Does anyone, do either of you know about that, heard of that?
I've not heard of that one yet, but I feel like every few months there's something new that has that claim.
I don't know about it either. Sorry. Cup, finger, or bottle. So more research really needs to be done. What's better, finger feeding or cup feeding more effective? A couple of studies showed that finger feeding was a little bit easier to manage for parents. They spilled less milk, can make a little bit longer feeding time, and some lower complications, respiratory in particular, during finger feedings versus cup feedings. And then another study talked to cup feeding versus bottle feeding in late preterm infants and really showed that the cup feeding was better as far as breastfeeding outcomes at discharge and after discharge, and there was no really significant difference in the length of stay. Feeding plan after discharge then is really kind of more of the same, making sure to, have time to relax with baby, really focusing on the positive, encouraging lots of skin to skin with mom, with dad, with partner, other parent, watching those feeding cues, and then making sure to maintain milk supply with pumping after feedings as kind of worked out in the feeding plan, so that when baby is really doing a great job, that the milk supply is there to support that. And those follow-up appointments are, of course, so important.
Okay, awesome.
Kara?
Thanks. So just a reminder of why we're doing this. We want to reduce the likelihood of feeding disorders. We want to try to reduce length of stay, reduce stress for families, and increase their confidence, and set those positive early experiences with skin to skin and positive feeding experiences. And in many places, this does require a culture change, and it may require a new focus on developmental and behavioral feeding cues. Asking yourself at any given feeding, is this infant really ready to feed orally? And being supportive rather than directive during those feedings. And just remembering that consistency is so important, as well as collaboration and staff education, and including the parents from the beginning. Just as Michelle said, asking, what are your goals for feeding your baby? And remembering that each feeding is a perfect time to educate them on the fact that it's dynamic, it changes. And this quote is also from that article I mentioned before. In any discussion of feeding readiness, we must continue to assess and reassess our own biases and understanding of oral feeding success. We must recognize that our feeding practices and comments are observed by other staff and families too. So you have a privilege to be part of such a vulnerable, special time in these families' lives, and they're looking to you for your expertise and your guidance and support. And it's paving a way for a lifetime of successful feeding. So thank you for your time and focus on that. And the bottom line, according to Dr. Parimi, is that we are producing children, not discharges. And then patient education resources. So these can and should be shared prenatally, since very few patients know that their babies will be born early and maybe have feeding problems. But they can be applied to full term as well. So the AAP is also big on responsive feeding. The link to this document is in the resources, and it covers a lot of good info about that. And so that's the link, that first one there. The video we showed is from New North Baby, Lactation Education Resources, Global Health Media, and these are the other ones that Michelle had mentioned too. And then we have quite a few resources, or references rather, if you want to look closer at those later. And then if we have a minute left, you're also welcome to email us at any time to share more about what feeding strategies work for you and your babies, what education you share with parents, and what resources you're looking for. I'm always wanting to receive that info from you, that feedback, so I can know how to best support you as the breastfeeding consultant for perinatal outreach. And as Kelly mentioned, there is a new webinar coming up June 2nd, and then the next two prenatal breastfeeding webinars are September 1st. I'll be focusing on milk supply, and November 3rd, I'll be co-presenting with Dr. Rabin about perinatal mental health. So save your calendars, save the date on your calendars.
Great. So I want to thank everybody who participated today. I want to thank Michelle and Kara for their work to present on this important topic. This has actually come up in a few different reviews of cases that I've done in hospitals. And I remember being a new nurse and there was always a nurse who was the expert in feeding, and they could feed any baby. And looking back on that, that probably wasn't a good thing either, to be force feeding a baby. And so I know that we have a lot of community lactation support today, but I just encourage also to share this with your hospital-based partners. And if you're a hospital-based nurse, please spread the word about this webinar, and it will be posted on the Perinatal Outreach website so that you can share with your colleagues. With that, I'm not seeing any other questions. There's nothing else in the chat box. And we are 1 minute after 1. I want to respect everyone's time. Feel free to follow up at any time. We'd love to hear your questions, comments, and suggestions. Thanks, everyone, and have a great day.
Do you want us to stay on for a few minutes, Kelly and Kathy?
Yeah, I was just asking Kathy to stop the recording.
Well, I can stop the share too.